Good evening. Welcome to SpectraCell's 2019 webinar program. Tonight we bring you Beware of Inflammation, Heart and Brain at Risk, presented by Dr. Bernarda Zenker. This webinar is being recorded and you will receive an email once the on-demand version is available. Slides and other educational materials are available for download in the resources box on the left of your screen. Be sure to download these resources before the webinar concludes. The resources will be available again using the on-demand link. You may submit questions in the Q&A box. If time permits, we will answer these at the end of the presentation. At this time, I would like to welcome back Dr. Zenker.
Good evening, Jessica, and welcome everyone that is listening in our audience. It's again a pleasure to be here with SpectraCell. And tonight we're going to be talking about inflammation of the heart, inflammation of the brain, and particularly the recent research that has come out over the last 3 to 5 years, 5 or 6 years, that have brought us to our present state of understanding of heart and brain both being a problem, and that they interrelate, they interconnect. So here I have the simple webinar objectives. Tonight we're going to be discussing markers of inflammation on the SpectraCell cardiometabolic test and how key nutrient deficiencies can predispose us to this inflammation. Importantly, we're going to be linking seeing the relationship of inflammation in cardiovascular disease and with brain dementia. And then we'll be providing some recommendations for the prevention of this inflammation that affects both cardiac and brain. So let's get started. Here we have a diagram of the United States, a graphic display of heart disease death rates from the time of 2014 to 2016, deaths from cardiac and heart-related illnesses, and as you can see, it's quite significant, particularly down in that southern central area of the United States. Death from heart disease is at all-time highs in those deep southern states, Louisiana, Mississippi, Alabama, Arkansas, Georgia. I grew up down there. I grew up in southern Alabama. I went to school in Louisiana, to medical school, nursing school and medical school. So I'm very familiar with the very rich food, southern fried chicken, shrimp, oysters, very high cholesterol foods, and it's just fed this heart disease death rates that we are now seeing on this map. And there are great things that we can do about it. That's what this webinar is going to be about this evening. Here is a nice graph that just illustrates that about 615,000 Americans die every year from heart disease. That's 1 in every 4 deaths. And as you can see, there had been a decrease in heart disease for about 2 decades. However, in the last 4 to 6 years, as you can see, there is an inching upward on that top green graph. Heart disease is again inching upward, and we want that to turn around, and so we're going to be talking tonight about some of the interventions that might be helpful with that. Here we can see in data published in 2016 that heart disease is the leading cause of death. It is out in front of cancer, just barely, but it is out in front of cancer. And if you look further down, you will see diabetes is there, Alzheimer's disease. Both of those, even though they're not part of the the cardiac cause of death. We're going to be talking about how those are intimately linked with cardiovascular problems. Here on this next slide, I've put together some of the direct and indirect cost of cardiovascular related disease and stroke. Here you can see that the total cost of all forms of cardiovascular disease, which include the heart disease, coronary heart disease, stroke, hypertension, congestive heart failure, all combined in excess of $286 billion annually. Then, in the accompanying graph on the right side of this, we see the approximate cost of Americans age 65 and older with Alzheimer's and other dementias, another $200 billion. What we're going to see tonight in this presentation is that cardiac inflammation can directly affect and lead to inflammation of the brain, leading to cognitive problems, including those memory loss, mild cognitive decline, and ending in dementia. If these figures weren't staggering enough, individually, when you add them together, looking at the resources spent on cardiac and brain health, the cost becomes overwhelming and definitely leading to bankruptcy, as we can see from our healthcare dollars. So here again, we look at the graph of the high cost of cardiovascular disease. This comes from the Center for Medicaid and Medicare in 2011, showing the top 15 chronic disease conditions for the year 2010. And if you look closely, 5 of the top 6 over on the left-hand side of the graph are the most common conditions, were all heart, vascular, cardiovascular related: high blood pressure, high cholesterol, heart disease, diabetes, heart failure. The number 6 that is not cardiac related necessarily is arthritis. But what they estimate, the Centers for Medicare and Medicaid estimate that if that our healthcare dollar is going bankrupt, and that by the year 2030, a mere 11 years from now, that we will be spending over $1 trillion in cardiovascular disease cost, unless we can put the brakes on this and do something about it with our patients. When we look at this particular pie chart, this was published in the Journal of Arrhythmia in 2014, depicting the categories of different causes of heart disease according to gender, men versus women. And we can see that the leading condition, heart condition, is coronary artery disease, both in men and women. In men, it is up at about 80%, and women only at about 45%. But as clinicians, the question is raised, what interventions can we institute that can change these staggering numbers? What are some clinical interventions that are workable, doable, and affordable for individuals? So as we go about answering that question, let's do a little bit of review of the most common type of heart disease, which is coronary heart disease. This depiction here is a brief graph schematic that shows the physiology of coronary heart disease, referred to as narrowing of coronary arteries. These coronary arteries are the blood vessels supplying the oxygen and blood to the actual heart muscle itself. Coronary heart disease normally occurs when cholesterol accumulates, as you can see here, in the artery walls, creating plaque. The arteries then become narrowed and blood flow becomes reduced, right where you see that middle arrow inching its way between two areas of diseased artery where plaque has built up. This process is called atherosclerosis, when that plaque builds up. As the plaque grows, the blood flow is less and less through the artery, and as a result, the muscles, the heart muscles themselves, cannot get enough blood or oxygen, and this can lead to dysfunctional muscle, frequently referred to as angina, pain of being generated by the heart muscles, and in severe enough can result in a heart attack. Most heart attacks will happen when a clot forms suddenly that can cut off blood supply, as you see in the distal part of this blood vessel, leading to permanent heart damage unless it can be rapidly stented in a cardiac cath lab. So here, let's look more closely at this process of atherosclerosis. And you can see that there are different stages of atherosclerosis. The fatty streak is the first stage of atherosclerosis. We have seen it in children as young as 10 years of age, particularly those with poor diet, poor nutrition, and genetic predisposition. In this fatty streak stage, we can see on biopsy, if that's unfortunate to occur in such young children, you can actually see fatty streak accumulation in major arteries, and such as the aorta and the carotid artery. The streak is made up of cholesterol and macrophages, and when it goes on and progresses, it becomes more at the fibrous plaque stage that is formed. When the fibrous plaque develops in the inner layer of a blood vessel, it can be made up of the smooth muscle cells in addition to the macrophages and lymphocytes and cholesterol. And as it grows, that's where the impairment of blood flow develops, and the blood flow becomes weaker and weaker. When you get into complicated lesions that can rupture, that's when very serious problems with the formation of clots actually develop. As you can see, this same process of fibrous plaque formation is similar in the brain, as unstable plaque formation can occur, leading to strokes in the brain. It's a very similar process that is going on, and it gets back to these fatty streaks, cholesterol accumulation in the blood vessels themselves. And what we now know is that this atherosclerotic process of the heart is a very similar process of the atherosclerotic process of the brain. If the heart is on fire, so to say, the brain can also be on fire. we're going to be reviewing some research this evening that links the inflammation of the heart as a potential trigger of the inflammation of the brain. And so let's turn to some of that research now. And what I will be presenting, a great many different research articles that you then will have at your disposal, going back and looking at the actual research that has been coming out over these last 3 to 5 years documenting this. So in this article from the Journal of the American College of Cardiology, we learn that inflammation after an acute myocardial infarction can determine subsequent inflammation or healing. There's this systemic interaction that may induce neuroinflammation as a precursor to neurodegeneration, which confirms that the brain inflammation can result from heart inflammation that occurred from an acute MI. So it's this direct link, inflammation from an acute MI directly interacting and predisposing to brain dysfunction. A very insightful article. We know that there are risk factors that can lead to inflammation. This is just a simple review that can lead to cardiovascular inflammation, cigarette smoking, high blood pressure, the bad cholesterol, LDL cholesterol, and diabetes. So let's turn to see how some of these directly lead to problems. Cardiometabolic syndrome is a combination of some of these dysfunctions. It's characterized by dyslipidemia, insulin resistance, impaired glucose tolerance, high blood pressure, and increased central obesity around the midsection. Interestingly, cardiometabolic syndrome, individuals with cardiometabolic syndrome are twice as likely to die from coronary heart disease. In addition, they are 3 times more likely to have a heart attack or a stroke than those that do not have cardiometabolic syndrome. So if we can make a headway in any one of these 5 areas, we can cut down on some of this astounding statistics. If we can work to have better glucose tolerance, better blood pressure control, decreased obesity, we will be able to impact some of these other dismal consequences of the cardiometabolic syndrome. So on the SpectraCell cardiometabolic panel, the cardiometabolic panel is divided into 3 main areas. Into vascular markers of inflammation. We're going to be talking primarily of these, the ApoB, the Lp(a), C-reactive protein, and homocysteine. But we're also going to be touching on the modifiable diabetic risk factors that are listed here, and how we can suggest interventions directly that can help with better glucose tolerance and diabetes. And then there are the cardiovascular lipid risk, the cholesterols, triglycerides, the lipid particles, and some interventions for these as well. So tonight, I've highlighted here in red some of these that we're going to be dealing with. The vascular inflammation markers, diabetic markers, and the big cardiovascular lipid risk, the particles, and the triglycerides. So let's start with the vascular inflammation markers and go over just a few of the definitions. I do get questions of these frequently in consults, and so let's just review these. The apolipoprotein B is a measure of all atherogenic, harmful lipoprotein particle in the blood and is typically described as all non-HDL particles. The way I remember it is when we were in school, everyone wanted to make A's. A's are good. Apolipoprotein A are your HDL particles. B stands for bad. All non-HDL particles are bad. They're inflammatory. So apolipoprotein B is bad. Apolipoprotein A is good. We wanted to make A's. We want as much HDL cholesterol as possible, typically. So that's how I have learned to remember it, and many of my colleagues. Let's go on and talk about Lp(a), lipoprotein a. It's an extremely atherogenic lipoprotein that is linked to blood clotting, spontaneous blood clotting. The Lp(a) cholesterol is thought to be genetically determined. It's the most atherogenic of all the particles and genetically determined and not very easily altered by lifestyle. High levels of Lp(a) may be a sign of increased risk of heart disease, and we don't have many interventions. We do have a few, and I'm going to share with you a couple on the horizon to be watching during this talk. But it's something to be mindful of, that it can cause a sudden oxidation of LDL, forming blood clots, and particularly when Lp(a) is elevated, we want to thin the blood and decrease inflammation as much as possible and prevent oxidation. For that reason, we want high-dose omega-3 fish oil, keep the blood thinned and decrease inflammation, and prevent oxidation of LDL cholesterol with good levels of vitamin E. And we'll be talking more in just a minute about these. So then let's go on to the C-reactive protein, an indicator of inflammation throughout the body, including the cardiovascular system. It is measured by a high sensitivity method and is considered an increased risk for heart disease. CPR is directly linked with low zinc and low magnesium. If you see a low zinc and low magnesium on a micronutrient test, be mindful that those low levels of essential minerals can be the stumbling block giving elevated C-reactive protein. And homocysteine is the last of the vascular inflammation markers here, and it's associated with causing a stickiness to your red blood cells. Elevated levels of homocysteine are directly correlated with low levels of vitamin B6, B12, and folate. It's typically thought to be a result of poor lifestyle and diet. The vitamin B6, as we'll see, is needed as a cofactor to bring homocysteine down into the transsulfuration pathway. And we will be reviewing a little bit of that biochemistry in just a few minutes. So tonight we're going to be talking about diabetic risk assessment as we see it on the cardiometabolic, and giving you some interventions of how to decrease some of this diabetic risk and how to evaluate it on the micronutrient test. Some of the parameters we'll be discussing. For the lipid fractionation profile, we're going to be discussing some of the interventions that you can look at the micronutrient test directly when offering interventions of how to decrease coronary risk. What are the micronutrients that are linked with some of those inflamed particles on the lipid fractionation profile, the C-reactive protein, your homocysteine, your Lp(a), some of the things that we can look at on the micronutrient to offer specific interventions. So let's go on and talk about a little bit about the influences on how can we intervene with atherosclerosis. Look at the lower left-hand corner. You see that blood vessel. It's almost a third to a half occluded with atherosclerosis, and you can take a look at that, of all the different influences that can increase the atherosclerotic process. Low adiponectin, low HDL cholesterol, elevated triglycerides, elevated LDLs, elevated angiotensin, elevated inflammatory markers, molecules being generated, perhaps even just by infections, TNF-alpha, interleukin-6, elevated C-reactive protein. Then in the upper right-hand corner, you see the insulin resistance. And insulin resistance affecting the liver in two different areas, one in steatohepatitis, sort of turning on that process of fat accumulation within the liver, causing a fatty liver. Secondarily, or in a second area, not necessarily secondarily, the insulin resistance increasing the process of increased cholesterol synthesis, and then directly influencing adiponectin that can influence the atherosclerotic process. So next I want to even get more at a deeper level and review exactly how all of this happens, even at a minute level, because this is going to tell us where we can offer intervention. So if you look at this schematic, find the number 1 in the middle of the lumen of the blood vessel. That's a blood vessel that's curved, and number 1 is right in the middle of the lumen, and where you can see that there is small, dense LDL particles that are more atherogenic than buoyant LDL, and they're inside the blood vessel because they can penetrate more easily than those buoyant LDL particles. So the buoyant LDL is considered LDL 1 and 2, and the smaller, dense LDLs are LDL 3 and 4. Now move to number 2, and you can see that number 2 is in yellow. It is the remnant lipoproteins. Those are scavenged by macrophage cells without needing to be oxidized, and can become a direct component of plaque formation. So that remnant lipoprotein taken up by macrophages inside the lumen, and then those become incorporated into the plaque. Number 3 are your Lp(a)s, that are LDLs that are easily oxidized and can become atherogenic. They are atherogenic, but they can become prothrombic. So you don't want these to become oxidized. easily. You want to keep the blood thinned and cut down on inflammation and prevent that oxidization process. Then number 4 is the HDL. Up in the upper right-hand corner, you will see that there's HDL helping HDL2B helping to remove excess lipids formed from HDL3 and is an indicator of how well HDL is clearing excess cholesterol from the body. And then number 5. Number 5 is where LDL oxidation is occurring in the intima of the blood vessel wall, and plaque formation is being formed with macrophages forming foam cells, the building cells of plaque. And what we know is that good antioxidants can help slow this down. And we can look for the antioxidant status on our micronutrient test for points of intervention. So when we look at the vascular inflammation markers, let's begin our discussion by talking about homocysteine. And with homocysteine, we know that there is a close association between low serum folate, this is methylfolate, not folic acid, but low serum folate and cortical atrophy in the hippocampal region, hippocampal atrophy. So when this direct article from the Journal of Alzheimer's Disease, 2014, is a documentation that we need methylfolate, not folic acid, but methylfolate for trying to reduce our homocysteine level and preventing this cortical and subcortical atrophy and hippocampal atrophy. Low folate is correlated with the atrophies seen with dementia, cognitive decline, and Alzheimer's. In this particular next article, again in the Journal of Biomedical Research, 2014, there is a relationship between plasma homocysteine and the behavioral and psychological symptoms of dementia. This is the discussion of this article. The study states that there is a significant correlation between high homocysteine and cognitive decline. So let's talk about how can we prevent this high homocysteine. And this takes us to a little bit of biochemistry. Don't everybody groan at once, but this is the simplified pathway of where homocysteine is formed in the methionine pathway, and at the entry point, if coming straight south through the CBS enzyme of how homocysteine becomes metabolized. And when we look at this, what we can understand is that there are 7 nutrient interventions that can influence homocysteine metabolism. The 3 that are most important in the literature are B12, methylfolate, and vitamin B6. But I would encourage you to do a micronutrient test side by side with this cardiometabolic, and when finding a homocysteine that is abnormally elevated, look for all 7 of these nutrients. Now, Dr. Bredesen from UCLA, the author of The End of Alzheimer's, is now recommending homocysteine of less than 7. Less than 7. It may not be enough just to look at B12 methylfolate and B6 to get the homocysteine decreased. We need to also be looking at the zinc, magnesium, serine, and cysteine. If all 7 of those nutrients are normal, then I would suggest look for the inhibitors of the enzymes that facilitate this pathway. Inhibitors such as acetaldehyde from candida overgrowth may block your MTR enzyme, for example. Lead and mercury may be blocking your MAT enzyme. So if your homocysteine is elevated, by all means, look for further investigation of the what other enzymes can be inhibited by toxins. And here I've just circled in yellow that you can see where those 3 main nutrients are needed: the methylfolate, the B12, and the vitamin B6. B6 is the cofactor for that CBS enzyme to bring homocysteine down through serine and cysteine down into the transsulfuration pathway. And when we look on a micronutrient test, here is where we find the 7 nutrients. This is why I so strongly encourage clinicians to do these tests side by side, so that when you find people at risk, that you can go directly to the meat of the problem and find where we can institute direct, specific intervention. So let's talk next about C-reactive protein, an indicator of inflammation throughout the body and a big risk for heart disease. In this particular study, and my talk tonight is riddled with the research that then you can come back to and study more in depth and pull the journal articles. In this particular study, what we see is that C-reactive protein appears to contribute directly to the cardiovascular risk and mortality even after multiple adjustments were made. And so when we have an elevated CRP, we know that there is marked increase in cardiovascular risk. This next article shows simultaneous presence of subclinical atherosclerosis and elevated CRP. And we saw earlier that this atherosclerotic process is one of the major risks for inflammatory disease, and that when we see an elevated CRP on the cardiometabolic, that we should automatically be thinking and tying that to possible atherosclerosis that can be occurring in the blood vessels, in the coronary vessels themselves. Next, an article that again is linking low-grade inflammation and C-reactive protein with obesity and the risk for both arterial and venal thrombosis. So again, even just low-grade inflammation with a CRP of less than 3 linked directly to the risk of myocardial infarction and thrombosis, even in the venous structure. Our next article, cumulative exposure with a high sensitivity CRP and subsequent risk of cardiovascular disease leading on to myocardial infarction. Another article documenting from 2017 the link between inflammation in the heart, cardiovascular disease, and C-reactive protein. So what can we do about this C-reactive protein? Here's a very nice study that links magnesium supplementation ability to reduce C-reactive protein in individuals with inflammation. So if you see on a micronutrient test low magnesium, number one, it should be triggering in our mind, oh, their CRP may well be elevated. Number two, leading them to increased risk for cardiac inflammation. Next, we're talking about zinc. Zinc supplementation compared to placebo decrease the concentration of CRP, interleukin-6, and these findings suggest that zinc has a protective role against inflammation and oxidative stress that can lead to cardiac inflammation and cardiac demise. So here we have two interventions, direct interventions, that can help decrease inflammation of heart and of blood vessels, zinc and magnesium. Again, another article indicating that magnesium reduces C-reactive protein in individuals with inflammation, and they measured C-reactive protein in elevation higher than 3, that magnesium can help those blood vessels not only vasodilate, but can help with decreased inflammation. Here's the next article, zinc again decreasing C-reactive protein. And so as a summary, the nutrients that we've just looked at and some comments. First about magnesium. There are multiple types of magnesium on the market. Magnesium threonate crosses the blood-brain barrier the best. Monitor creatinine in the elderly. Too much magnesium in an elderly person with compromised renal status. Too much magnesium can worsen renal status. So I just put a plug there to monitor those creatinine levels in the elderly. And magnesium, particularly magnesium malate, can help to bind arsenic and aluminum, heavy metals, and carry them out of the body. Arsenic and aluminum can both complicate the mitochondria, can inhibit the mitochondria, and so getting rid of them will also be helpful. Zinc glycinate is one of my favorite forms of zinc. It's very well tolerated orally. Zinc picolinate is the least expensive form of zinc, but if you take it on an empty stomach, it can lead to nausea. So I always encourage my patients, take zinc picolinate with food. Zinc carnosine helps soothe an inflamed GI tract. And zinc is needed for many, many enzymes in the body, but I always remind our clinicians that the optimal zinc-copper ratio is approximately 12 to 1. The food that is highest in zinc in the American diet is red meat. The food that is highest in copper are seeds and nuts. The ratio in red meat is 20 to 1, 20 milligrams of zinc to 1 milligram of copper. In seeds and nuts, that ratio drops to about 5 to 1. So depending on your patient, you can make dietary recommendations for nutritional sources of zinc. And we know that inflammation is related directly to C-reactive protein. And all of these are interventions. This is a very nice tool that SpectraCell has given us with documentation of the different interventions that we can use to help decrease inflammation in the body, and the documented references there. So I just want to bring this inflammation wheel back out so that to refresh our memory of how this can be helpful as well. So let's go on and let's talk about lipoprotein little a. LP little a, extremely atherogenic, the most genetically determined atherogenic particle that we know of. And this is a very, very simplified schemata of LP little a, as we call it. It's an LDL-like particle with a molecule of apolipoprotein B100 linked with a disulfide bridge to apolipoprotein A. And if you look closely, you can see that disulfide bridge, SS, linked together. It's the ApoA component is similar to plasminogen in terms of structure and competes with plasminogen for binding sites, resulting in reduced fibrinolysis, which means that blood clots don't get broken down very as much as easily. And it is why that in the literature you will see if somebody has high LP little a, there is some recommendation for using things like nattokinase that inhibits fibrinogen from clotting. Things like nattokinase can help reduce LP little a from causing blood clots, but I would urge to be cautious in using nattokinase in any actively menstruating women because they may never clot off at the end of their menstrual cycle. So that's just a word of warning with that. With LP little a, we do know that a few little things about it, and I've listed different points of information here. Niacin is the most effective pharmacological agent to reduce LP little a that we know of. Lifestyle changes really don't change LP little a significantly. Statins don't work very well in reducing it. Niacin is about the only thing that we know that can reduce it. However, niacin can appear to lower LP little a, but that doesn't mean that niacin in lowering LP little a necessarily prevents the formation of a sudden heart attack. So we can use niacin to reduce LP little a. I would encourage high-dose fish oil, a minimum of 2 grams, even up to 4 grams per day, to keep the blood as thin as possible to help prevent clotting from occurring, to help decrease inflammation, and then also look at the references with using something such as nattokinase in an appropriate patient. We know that niacin's mechanism of action is to decrease free fatty acid mobilization. It can help decrease VLDL synthesis, LDL and triglyceride, and it has been shown to help increase HDL to a point. But again, a warning here, niacin may lower LP little a, but it may not reduce the risk of a sudden heart attack. So again, just to keep that in mind, that we still need some of those other interventions. So something to watch. There are a couple of slides here I've just put in. What else are we seeing that might be helpful in the literature coming up that demands more study and more clinical trials for decreasing Lp(a)? There are a couple of studies here that indicate that L-carnitine might be helpful, and that coenzyme Q10 may be helpful in decreasing levels of Lp(a) in patients that have elevated Lp(a). So again, this is not ready for prime time. We still need more clinical trials, but it's something to be aware of. It's something that in the appropriate patient you may want to try and then reevaluate L-carnitine and coenzyme Q10. And a second article documenting the L-carnitine supplementation, again, for your reference and for further investigation to be aware of in those patients with really high Lp(a). And again, CoQ10 may be also quite helpful. Something to watch. So some of these nutrients, niacin, yes, but then be mindful that acetyl L-carnitine and CoQ10, I've denoted them here with question marks, may be up and coming to help with decreasing Lp(a). Cholesterol. So let's turn to the diabetic metabolic risk as measured by the diabetic metabolic risk evaluation. And I've listed here on the left all of the different things that we look at when evaluating someone for their type 2 diabetic risk: insulin, glucose, hemoglobin A1C, the C-peptide, adiponectin, the C-reactive protein, triglycerides, and HDL. So what I want to do is take the diabetic markers as a whole and then talk about a few things that can influence obesity and diabetes as interventions that we can use in our practice, showing the studies. So here's a very nice article that documents a positive trend established between giving vitamin D and increasing adiponectin. We know that when adiponectin falls, that is a bad sign that type 2 diabetes is right around the corner. So again, a trend between giving vitamin D, and which will encourage an increase in adiponectin. Next, adding biotin with chromium. Biotin, as you know, is required for metabolism of carbohydrates. Chromium is required as a trace mineral for the appropriate functioning of glucose-insulin interaction. When we added, this particular study documents the effect of supplementing chromium and biotin on improving glucose, insulin sensitivity, decreasing insulin resistance, that's HOMA-IR, insulin resistance at the cellular level, and leptin and lipid profiles. Now, for biotin, we recommend 1,000 micrograms of biotin at least per day, and chromium 200 micrograms up to twice a day. that will improve glucose insulin metabolism. In this next study, again, biotin and chromium improving glucose metabolism and triglyceride levels. So again, we know that elevated triglycerides can potentiate that atherosclerotic process, and we don't have a lot of ways except exercise, direct exercise, to increase HDL cholesterol. But here's a very nice study that documents that chromium and biotin both increased decreased triglyceride levels and increased HDL levels, and helped with diabetes in that pre-diabetic picture. Another intervention point here is with alpha lipoic acid and curcumin. In this particular study, the giving both curcumin and alpha lipoic acid together had a more positive effect than either one individually. And we know that curcumin decreases inflammation, so it makes good sense how these two can potentiate each other. Alpha lipoic acid is needed for your metabolism of carbohydrates. So again, better metabolism of carbohydrates and better decrease in inflammation. Highly effective in decreasing body weight. This particular was on weight gain and adiposity, and giving curcumin and alpha lipoic acid together, very helpful. The next study, magnesium again, with decreasing not only coronary heart disease, but with type 2 diabetes, giving magnesium, again, because magnesium is needed for so many different enzymes helping our cofactors, enzyme cofactors throughout the body. It makes good sense biochemistry of how magnesium supplementation can lower coronary heart disease as well as type 2 diabetes. So here we're talking about nutrients for decreasing diabetic risk, alpha lipoic acid, chromium, biotin, magnesium, and zinc. So again, when you're working with patients and you have somebody with a high or a moderate risk factor for in their diabetic risk assessment, as from this particular example, we can take these 5 interventions and go directly to the micronutrient test, looking at their biotin level, their zinc level, their magnesium level, their chromium level, and their alpha lipoic acid level, and incorporating interventions where needed with the appropriate interventions. And I bring us back to another tool from SpectraCell, their diabetic wheel, that has the documented, researched interventions, all that we can incorporate directly to help prevent diabetes and to treat diabetes. Even some that we haven't talked about tonight are listed here, such as carnitine. Carnitine you have to have for the mitochondria. You won't be able to produce energy by the mitochondria. CoQ10 for the mitochondria as well. So when you give these interventions that can help produce energy utilizing glucose in the body, you have better glucose management and a decrease in your diabetic risk. So nutrients important. Let's go on. Nutrients important for heart failure. Again, nutrients directly from the micronutrient test that we can link back and forth between our heart failure risk factors such as high triglycerides, low HDL, elevated homocysteine, etc., going directly to the micronutrient test and seeing where there are points of intervention. And again, this is one of the tools that SpectraCell has put together of the pertinent micronutrients that can positively impact our dyslipidemic patients that we can encourage. Here is the example here of a patient with vascular inflammation and biomarkers that we're seeing. And on this particular patient, as you can see, C-reactive protein is elevated and homocysteine is elevated. So what would we do with a patient such as this? Directly for your C-reactive protein, we want to be thinking about zinc, magnesium, vitamin D3. We want to be, for homocysteine, there are 7 nutrients to be looking at. Our B12, methylfolate, and B6 that we talked about. But don't forget that zinc and magnesium again, serine and cysteine, critically important. And here's patient number 2 when we're looking at our pre-diabetic risk for, again, moderate risk. We want to then turn to what could we do? Chromium, biotin, alpha-lipoic acid, magnesium, and zinc. We've seen the research tonight documenting that all of these interventions can directly influence decreasing inflammation, decreasing C-reactive protein, in increasing glucose utilization. And then on our final slide here, I will just want to put forward again the summary sheet that comes with the cardiometabolic test results, always that are the guidelines, therapeutic guidelines of recommendations of how to best recommend lifestyle changes, increasing omega-3s where appropriate, based on the lipoprotein fractionations that are detected in a cardiometabolic report. I encourage all my clinicians, find a color printer and print this out in color, put it in a plastic sheet, and have it accessible there in the office for frequent reference. And Jessica, this brings us to the end of my slides and our presentation for tonight.
Thank you, Dr. Zenker. This concludes the webinar. Be sure to visit our website for next month's webinar on Why SpectraCell, presented by Dr. Haley Hurd. Have a wonderful evening.